Welcome to the Neurocritical Care Society podcast. My name is Joshua Levine. In this episode, Dr. Starane Shepherd will interview Dr. David Hwang from Yale about a paper he recently published in Neurocritical Care entitled Factors Considered by Clinicians When Prognosticating Intracerebral Hemorrhage Outcomes. Without further ado, here's Starane.
Hi, I'm Starane Shepherd, Assistant Professor of Neurology in the section of Neurocritical Care at Rush University Medical Center in Chicago, Illinois. My guest for today's episode is Dr. David Hwang, Assistant Professor in the Division of Neurocritical Care and Emergency Neurology at the Yale School of Medicine. His academic interest includes how clinicians prognosticate outcome for patients with intracerebral hemorrhage. He's the author of a paper on this very topic published in Neurocritical Care entitled Factors Considered by Clinicians When Prognosticating Intracerebral Hemorrhage Outcomes.
Starane, thanks so much for having me.
Intracerebral hemorrhage is a disease that we often encounter in the neurocritical care unit, and as we know, there is a high mortality rate and disability, and we often rely on scales such as the Hwang score and the ICH score to help guide us and families in prognostication. And I saw that you previously published a paper in 2016 where you compared subjective judgment to these scales and found that clinicians outperformed these scales. What do you think accounted for that finding?
Well, that's an interesting question, Starane. I think that when we initially, when the group that put that paper together initially conceived the study, the original hypothesis was that the ICH score and the Hwang score would outperform subjective clinical judgment of physicians and nurses with regards to predicting accurate outcome for ICH patients. There have been similar studies that have been done with ischemic stroke scales where ischemic stroke cells had outperformed clinician judgment, at least when people are given hypothetical vignettes. And so the original hypothesis of that study was that the scores would outpredict the clinicians. But it turned out it was the reverse that we found. You know, the clinician scores actually correlated more closely with 3-month outcome than the ICH and Hwang scores. And I think the reason for that is even though the ICH and Hwang score, or the ICH score in particular, and the Hwang score to some extent have been externally validated, at the end of the day, there are factors that are available to clinicians at the bedside that are simply not accounted for this, in the scores. The scores don't include things like medical comorbidities for the most part. There's all the sort of quote-unquote soft stuff, right? Patients' social economic situations and families and social support and all these things that I think that clinicians put into their formulations when they're predicting how a patient's going to look at 3 months. And the ICH score and the Hwang score, as useful as they are, they don't account for that for individual patients. I think when you talk to folks who are involved in the creation of both those scores, they will readily admit that there is value in looking at prediction of outcome on a population basis, just to get a feel for what types of patients tend to do well and what types of patients don't. But the authors of both of those scores will argue against, or at least caution folks against using the scores for prediction of outcome for individual patients for precisely this reason, that every patient comes in with different factors that may not be associated or may not be incorporated in the scores themselves.
So that brings us to this recent publication. So what was the hypothesis of this study?
This study was actually sort of a sister study to that prior study you brought up initially. So in that study, in addition to having doctors and nurses give predictions of outcome for how ICH patients would do at 3 months, we actually asked folks to list what factors, subjective factors they were using, give us their thoughts, so to speak, as to how they were coming up with their formulations. So I think the purpose of this study was to take that data and explore it, explore the responses that clinicians wrote, explore the factors that nurses wrote, and do a couple comparisons. We wanted to see if we could identify or get a sense for what factors clinicians, both physicians and nurses, were using outside of the ICH and Hwang score when making their formulations. We wanted to also take a look at physicians and nurses as groups and to see how they think differently and whether or not they were using different factors for outcome prediction. What we were hoping to do, and we can talk about this more, what we were hoping to do is to take a look at those factors for clinicians who made accurate outcome predictions, and those that made inaccurate outcome predictions, and see if we could learn anything from, whether or not there were any factors that were particularly helpful, of course, with predictions, which is, of course, what we want to do as clinicians.
So just to clarify, it was a survey-based prospective observational study.
Correct.
Okay.
Yeah, so the way it worked was there was a 2-year period where we sort of piggybacked the study off the ERIC database. That was a prospective observational study that was funded by the NIH at 19 different centers. So this study, as you mentioned, is a prospective survey study where we enrolled patients who were already being enrolled in the ERIC database. And for those patients, we surveyed physicians and nurses within the first 24 hours of patient admission to get their sense of, number one, what they thought 3-month outcome was going to be, and then number two, what factors they were considering in their subjective judgments of outcome.
And which patients were excluded from this study?
Really, we wanted to focus on impressions that physicians and nurses had of ICH outcome, basically when the patient comes in the emergency room or when they hit the ICU. If I had to sum up the inclusion-exclusion in a nutshell, we were looking at patients who had primary ICH, not secondary cause of ICH, adult patients that were coming to ICUs. And we tried our best to capture physician and nursing predictions of outcome and their subjective judgments within that first 24 hours of the patients coming in the hospital. So any patients that were missed in that window were excluded from this particular study.
And on the survey, what were the questions that you asked?
Yeah, it was literally a 1-page survey. Basically, we just asked folks at 3 months, what do you think the modified ranking scale for this patient is going to be? And then there was just another question that asked, list up to 10 factors that you're using in this prediction. And it was basically free form. It wasn't multiple choice. There weren't any other prompts. There were just basically 10 blanks on a piece of paper. And so we got all these surveys back, from physicians and nurses, and we had to figure out a way to sort of organize the data. We took a look at what had been written in each blank and started categorizing the ones that were similar to one another. And basically, as we started counting, different responses and putting ones that were similar together, it became pretty clear that there were, I would say, 8 major sort of categories, I'd say, or we call them domains in the paper, basically categories of factors that we could organize each of the individual things that were listed into. So things like age, GCS, things that we're familiar with. And then we started looking at things that came up repeatedly that were not part of the ICH-1 func score, but that seemed important. So things like pre-existing comorbidities, pre-existing functional disability, and then this aforementioned listing of predetermined limitations of care. So if someone wrote that the family was predisposed to comfort care but had not quite made a decision, that got its own special category. And then we had other non-clinical radiographic factors, things like patient personality, patient social situation, psychosocial factors.
Okay, so that brings us to the results of the study. So how many patients were enrolled, and what was the breakdown between surveys that were completed by physicians versus nurses? And of the physicians, were most of the physicians attending physicians or trainee physicians?
Yeah, so great question. So we ended up enrolling 121 patients in the study over 5 centers. Each patient had 1 physician prediction and 1 nursing prediction. There were 36 attending physicians total that participated and 16 trainee physicians that participated. 91 of those predictions were made by the 36 attending physicians, and 30 of those predictions were made by 16 trainees. The nursing surveys, that was completed by 76 nurses.
And then just comparing the responses between physicians and nurses, did you notice that there was any difference in the decisional factors that clinicians consider in outcome prognostication for patients with intracerebral hemorrhage?
We did. We did notice some differences that I think make sense in the context of our workflow for physicians versus nurses. So the first thing I'll say is that if you just look at the physician and nurses together, there are a fair number of variables that are components of the ICH and func score already, and that's not surprising. For example, 41% of the surveys listed age, 57% listed something about the clinical exam, 43% listed ICH volume, and then 20% listed things that are not even clinical or radiographic factors, so to speak, but it's these soft things that we were talking about initially, things like the patient family support system, the personality of the patient, these sort of things.
Yeah.
To get to your question about physician and nurses, it turned out that nurses tend to focus more on components of the GCS motor score or components of the GCS verbal score component, these things that are sort of bedside exam findings, they were much more likely to list those as factors they were considering for prognosis. And they were much more likely to list non-clinical radiographic factors, so like things like the patient and family support system or the patient personality, whereas the physicians were much more inclined to list things that you would only find on neuroimaging, things like, the ICH location being the big one, presence of intraventricular hemorrhage, things that you would only know from looking at the CT scan. I think what is notable about those findings is the physician nurses overall, they had a similar accuracy. Like their accuracy was almost identical, like as a whole, with regards to their prediction of accurate outcome.
And what percentage of these surveys were accurate at predicting 3-month MRS?
So of the 121 physician surveys, 37 were accurate.
Okay.
And of the 121 nursing surveys, 36 were accurate.
Okay.
So that kind of gives you an idea of
so that's pretty
exactly
similar.
how close the two cohorts were. They're basically almost identical. Yeah.
Was there any factor that was consistently accurate in predicting outcome?
The only thing that we found that I think was significant, we found this reassuring in terms of the validity of the study, but it's not particularly helpful, is the fact that for those few surveys that did list predetermined limitations of care as a factor, the vast majority of people who listed that on their survey, if they did, those were accurate. We found that to be the same for both physicians and nurses. To answer your question, though, I think what we're interested in, obviously, is other factors, whether or not they're components of the ICH score, Funk score, or not, that were particularly helpful. And we weren't able to uncover anything that, any factors that in particular seem to correlate with more accurate outcome.
I thought it was interesting that clinicians often listed components of the ICH score, but apparently only 3 physician surveys explicitly listed the use of a formal ICH scale. Why do you think that occurred?
I agree with you. I think it was an interesting finding, and I'd be curious what your thoughts are. My interpretation of that is that accurately reflects how people work. For example, like I know personally when I'm predicting outcome for patients, I personally rarely ever take the numbers that come out of the ICH score and just use that alone in a vacuum. I think in practice we look at these components, things like the age and exam severity and volume and location. We're all sort of factoring that in. But I suspect that this is accurate, that there's probably not too many of us that are calculating the score and then looking at, the outcome table and then using that alone. I feel pretty confident about that at the institutions I've worked at, but I'd be curious about your own experience too, whether or not that seems to reflect what your practice has been, what your training has been, or if this was more surprising.
Yeah, definitely. I agree. So the ICH score, I think, is something that we record on every admission for ICH, but in talking to families, I base my prognostication more on other factors. Some of them were actually listed here, like the location, just, the coexisting comorbidities, especially the patient's age, and what the patient would have wanted for themselves, just talking to the family members, more so than the ICH score itself.
I agree. And this study was 121 patients at 5 different academic centers, and so my guess is that what we're seeing here could probably just be taken at face value. That there probably are very few clinicians at academic centers that are incorporating formal clinical scales into their predictions. And I think that's sort of, I'm glad you brought up the point, because that could sort of bring up this idea of whether or not that's a good thing or a bad thing. Oftentimes for individual patients, the clinical judgment may just simply be more accurate than what the scale suggests. Usually when we're talking with families, we're giving a range of particular outcomes as opposed to, a single percentage for a single modified ranking scale outcome. And so I think from that respect, using the scales can be difficult too if you're just focused on a single type of outcome like functional independence or, mortality, whereas the family might be interested in other outcomes that are important to them. On the one hand, we know that between clinicians, there's a huge variability with regards to how we feel patients are going to do. On the other hand, the quote-unquote best scientific tools that we have, they don't even seem to outperform clinical judgment. So it really puts us in a difficult position with regards to trying to cite numbers. And it means that, the use of the scales themselves in clinical practice, it definitely requires a lot of thought.
Yeah. We often talk about self-fulfilling prophecy in patients with intracerebral hemorrhage being a factor for the possible bad outcomes that we see in this disease process quite often. However, in your paper, you found that clinicians tended to be more optimistic than pessimistic in their prognostication. Why do you think this occurred?
That's a great question, too. So we have to be a little bit careful just because, and we tried to be careful about this in the paper, but there were a fair number of patients who didn't qualify for the study because they were made comfort measures only in the first 24 hours, right? So we excluded those patients because, for obvious reasons for the study, the idea is to look at factors that predict outcome. For those that are already deemed comfort measures, it would make sense that they shouldn't be in the study, for fear of biasing the study. But I think the concept of the self-fulfilling prophecy is still a controversial one. There have been recent papers that have sort of argued against its existence and that sort of thing. But this study can't comment on, those that were made comfort measures only hyper early, super early in the hospital stay. It's possible that group that was excluded, that there's large susceptibility to the self-fulfilling prophecy for that particular group. We don't know off the bat whether or not, those patients were withdrawn appropriately or not appropriately. But I think there is something to this idea that, we as neurointensivists, a lot of us have been trained to avoid the self-fulfilling prophecy, and we're trained that folks can improve, and it is true, folks can improve from intracerebral hemorrhage, but I think families definitely need to hear the hard truth.
Yeah. Well, David, this seems like a great point to end this discussion today, and I'd like to thank you for taking time out of your busy schedule to discuss this paper with us.
It's a pleasure, Starane. I appreciate the podcast committee's attention to it, and we hope the study is enlightening to folks.
So that was Dr. David Hwang, Assistant Professor in the Division of Neurocritical Care and Emergency Neurology at the Yale School of Medicine, and we were discussing his paper, Factors Considered by Clinicians when Prognosticating Intracerebral Hemorrhage Outcomes, recently published in Neurocritical Care.
This podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. The Neurocritical Care Society provides and advocates for the highest quality of care for patients with critical neurological illness throughout the world. Follow us on Twitter @neurocritical, on Facebook, or visit www.neurocriticalcare.org for more information about NCS and the comprehensive resources that it offers. On behalf of the Neurocritical Care Society, thanks for listening.